Welcome you all towards today's topic, that is the history and clinical examination of the respiratory system. In the clinical posting, you have already covered this respiratory system, and probably you have seen some cases of pleural effusion or any lung mass or any collapse. So we are discussing regarding the history taking and the clinical examination of the respiratory system. As per the knowledge you gather till now how to take the history, that's the particulars of the patient. You already know it, but still some recapitulation, and it includes the name, age, sex, address and occupation of the patient. Now come to the chief complaint or presenting complaint. In respiratory system, there is mainly following complaints are there. The patient come with the following complaints. It may be cough, it may be expectoration, hemoptysis, breathlessness, chest pain, wheezing, and loss of appetite and loss of weight. There are a number of complaints will be there, but you have to choose which is the most important for this patient, and patient will tell about most of the symptoms of his suffering. Now we start with the cough. It is the most common complaint that patient presented with the cough. Whenever you take the history, you have to take the history of duration. Either it may be acute or chronic onset. And in case of most of the respiratory system cases, you will not get probably any acute case, or you will get the case either hemodynamically stable and chronic. So during the duration, you have to take whether it is acute or chronic. Acute means it occurs within 3 weeks, and chronic means more than 8 weeks. And onset, that is already described, that is acute or chronic, or either onset is insidious is progression. Now come to the episodes. Episode, that's mean it occurs in bouts of cough. It may be in the continuous form. I have to get the information from the patient. And aggravating factor and relieving factor. In the cough, there is some aggravating factor. It may occur particularly a change in the posture. It may aggravate, or following exposure to some particle. It may aggravate, or there may be associated with some other problem, like in case of GI problem, in case of GERD, the cough is increased, and it's some relieving factor is also there, either by taking medication or taking any posture, it may be relieved. And variation is very much important whenever you are thinking it is a case of chronic disease like your asthma or bronchitis or COPD. In case of asthma, it is termed as it is episodic in nature. That means occur any particular episodes, and in between the time patient remain asymptomatic. And the episodes may be like that. It may be diurnal variation, that means more occur in the early morning or during the time of night, and seasonal pattern is there. Particularly some of the patients get more cough in the winter season, some get more in rainy season, and in between the summer season patient may be normal, or there is no symptom at all. And there is some postural variation. Postural, that means the patient get cough in lying down position. That means it involves any GERD related complaint. Now second one is the expectoration. On the expectoration, you have to take the history of duration, for how long it is there, and the onset. And then comes to the progression, whether this expectoration remains same or it is increasing gradually. All of these have clinical importance, because the duration, if it occurs very early, and it may be associated with any acute onset, so it may be due to the exacerbation of the underlying cause, or in case of it occurs in the acute onset and is associated with the breathlessness, so it may be the feature of cardiac issues like congestive heart failure will be there. And now come to the episodes. You have to take the history, and there is another thing, there is the quantity, color and consistency and smell. These also identify whether it is infective or non-infective. And the quantity is, if it is very small, or it is the copious amount in the early morning, it occurred in episodes, so it may point towards the bronchiectasis, or it is a chronic cause. And now comes to the color, will also help you to identify whether it is infective or non-infective. If it is greenish or yellowish, so it is more towards infective. Whether the serous color or mucoid, that means it is more towards the chronic case. And the smell, if it is foul smelling, it may be related to the lung abscess. Now expectoration, there may be some aggravating and relieving factor. and variation, particularly there is the postural variation. Postural variation, and it is very much important in case of bronchiectasis. That means if the patient on the lying down position, a patient get more of expectoration, that means the lower lobe is involved, while in the sitting position there is the upper lobe. Now we come to the hemoptysis. Hemoptysis, that means the blood, that sputum containing the blood, it may be the streaky or it may be frank blood. And you have to know about the duration, onset, progress and episodes. And you have to identify whether it is a fresh blood or altered blood. Fresh blood means there is a red color. That is mainly occur in case of bronchogenic CA, tuberculosis. And altered blood, that means it is of color of blackish, more towards blackish, that is the altered blood. And amount is very much important because if one day within a 24 hours, if the hemoptysis or the expectoration of the blood is more than 600 ml or that causes the hemodynamic instability, we termed it massive hemoptysis. And we have to know what is the aggravating and relieving factor also. Now breathlessness. Breathlessness, when we describe the breathlessness, we have to first to know the duration, then onset and the progress. Another duration, it may be the acute onset or it may be the insidious onset or it may be the chronic, and how long it is there. Now come to the progression or grade, and it has been graded according to the MRC scale. And you have to know whether this breathlessness is episodic or not. Mostly the episodic means it is associated with airway disease, and whether it is associated with any orthopnea and PND. And this breathlessness, whether this aggravating factor, particularly in case of any exertion, if it aggravates or relieve after taking rest or medication, that will also help you to understand whether it is related to the pulmonary or it is to the cardiac cause. And associated wheeze, it indicates either asthma or COPD. Now come to the chest pain, and the format remains same. There is the duration, onset, progress, episodes. Another different types is the type and radiation. Type and radiation means whether it is peripheral or central. Peripheral, that is the sharp, stabbing and increase on respiration or coughing. That indicates the pleural cause. And whether it is central, poorly localized, dull, aching chest pain, that indicates mediastinal origin. And you have to take the whether it is aggravated by any other symptoms or there are some relief after any medication or taking or change in the posture. Now come to the wheeze. Wheeze, that means there is a whistling sound that occurs from the mainly airways, and you have to know the duration, whether it is acute onset or chronic onset, then progression and episodes. We have already described it, and this variation is very important, whether it is seasonal variation or diurnal variation. And associated with any skin rash, allergy, there is the dust, food, pollen, etc., that indicates the asthma. And loss of appetite and loss of weight, and that is mainly associated with the chronic cases. Whenever you are doing or thinking of any related to any pulmonary tuberculosis or any related to any malignancy, the patient will definitely give history of loss of weight and loss of appetite. Now overall the history of patient illness is over. Now come to the past history. Past history, that is very much important in case of pulmonary medicine, that is the history of tuberculosis or any past history of ATD intake. It may be two types, it may be the for pulmonary origin or extrapulmonary cases. That means the patient may take anti-TB medicine for any pulmonary or any pleural effusion or extrapulmonary like your abdominal or lymph node tuberculosis. And immunization history is very important because of the recurrent childhood infection may result in the bronchiectasis. And also the diabetes, hypertension and heart disease is very important. Particularly valvular heart disease, it may imbibe further chest infection, and at the same time the heart disease, particularly in the form of coronary artery disease or reduced ischemic disease, that results in heart failure and leads to the pleural effusion and also the breathlessness. Now, history of drug intake. History of drug intake particularly important in case of chronic cough, particularly ACE inhibitors and NSAIDs. These are mainly involved in the cough and drug-induced asthma, and at the same time a few other medications are there that leads to the pleural effusion. And history of any surgery. History of any surgery that is related to the any trauma or any thoracotomy, or it may be leads to the chest deformity, and which we identify and we can able to know that there is a history of certain illness that leads to the presenting complaint. Now, family history. Some of the respiratory disease, particularly the airway disease, are very much familiar. It is the asthma, allergic rhinitis, and history of the COPD, and family history of the lung cancer, diabetes, and hypertension. Now, personal history. In case of respiratory medicine, the personal history is very important, and particularly the occupation. Occupation is particularly the occupation related diseases are much more common, because the certain period of time, if the patient is exposed to any foreign particle or any dust particle, it may lead to the airway disease, it may lead to hypersensitivity pneumonitis, it may lead to COPD, or it may lead to the interstitial lung disease. And at the same time, we have to know about the diet, sleep, appetite, bladder bowel habits. There is already you know it, and extra we have to take the addiction. This is very much important, particularly the smoking. And the smoking, we have to know there is a duration, amount we you have to express it in the form of pack years of smoking index. And another is the alcoholism, and these things are very much associated with malignancy and also tuberculosis. And now come to the general physical examination. It is almost same with the general medicine you have already taught, and here we just follow the things. There is the patient position. There is the patient is either sitting comfortably or lying in particular side. That means patient is some pathology in the chest or some respiratory distress. Otherwise, patient is conscious, alertness. These are very much important, particularly in the COPD patient. Patient is altered mentation and headache, or patient is confused. That means there is CO2 retention. And build is very much important, just to know whether it is origin is chronicity or there is acuteness. There is a height, weight, and BMI. Now, like general survey, there is a pallor, icterus, cyanosis, edema. Clubbing is very much important in respiratory medicine, because particularly in chronic cases, in case of bronchiectasis, lung abscess, empyema, and lung cancer, you can see the clubbing. And at the same time, in case of the lung cancer, there is a hypertrophic osteoarthropathy is there, and lymphadenopathy. Lymphadenopathy, that means there is a cervical, axillary, and inguinal lymph nodes. And you have to know there is the pulse, BP, respiratory rate, and JVP is important, particularly in case of your superior vena cava syndrome, where the JVP is raised but it is not pulsatile. And you also know the temperature, just to identify whether it is acute or any infective or non-infective. And also to know the thyroid enlargement, skin, hair, and nail condition. And if the patient is given in the ICD, actually, though any patient could not be able not to be given in examination, but there may be sometimes the ICD is given in either of hemithorax, just to evacuate any effusion or any air. That means either pleural effusion or pneumothorax. Now come to the some areas before going to the respiratory examination. There is a very much important. First one is the supraclavicular area, and that means this area that is above the clavicle, space above the clavicle. There is the infraclavicular area from second intercostal space from clavicle to this area is the infraclavicular area, and this is the inframammary or spaces below the infraclavicular area. That is the second to sixth intercostal space, that is called the mammary area. And there is a triangular space that is called the top space. It is already taught, and this top space there is a on percussion note there is a resonant. If it is obliterate, so we can know that either it is due to the splenomegaly or it is due to the any collection, that is the pleural effusion. Now come to the some lines are there. There is the axillary area, infraaxillary, and this axillary area there is a space up to the fifth intercostal space in the mid-axillary line. There is the axillary area and infraaxillary area below the fifth intercostal up to the seventh intercostal space. And posteriorly the spaces are suprascapular, interscapular, and infrascapular spaces. These are the suprascapular, interscapular and infrascapular. Now come to the some lines are there. There is the mid-sternal line, there is the vertical line in the middle of the sternum, parasternal. There is the vertical line along the lateral edge of the sternum, mid-clavicular. There is the vertical line of the midpoint of the clavicle. There is this area, this one, and anterior axillary line. There is the vertical line along the anterior axillary fold, this one. And these lines and spaces are very much important during the examination of the respiratory system, particularly to know the pathology of the lung involved and which lobe of the lung is involved. Now there is the surface anatomy of the lobes. There is already been taught in your anatomy classes. In the right side there is a 3 lobe, upper, middle and lower lobe. Actually oblique fissure that divides it into the right upper and right lower lobe, and from the hilum another arbitrary line is drawn on the oblique the line, and that divides in the upper lobe in the right upper and right middle lobe, and the left side is the only one line is there that divides in the left lung into the left upper lobe and the left lower lobe. That is the oblique fissure. Now there is a topographic representation of the lung, both lung. There is a on the posteriorly there is this portion belongs to the right upper lobe. There is the right lower lobe. And this is the left portion, there is a left upper, and this portion is the left lower lobe. And from the side, this one is the left upper, left lower lobe, and this portion is the right upper lobe, right middle and right lower lobe. Now come to the examination of the respiratory system proper. So we divide into the upper respiratory tract. There is arbitrary division that from the nostril up to the larynx, and from below that portion is called the lower respiratory tract. And the upper respiratory tract is very much important just to know some pathology in lower respiratory tract. So we first start with the nasal cavity. Okay, whether any sinus tenderness, any DNS or flaring of the nasal alveoli, nasal polyps, this almost all these things are important. Particularly sinus tenderness that give rise to the any sinusitis there, and that leads to the postnasal drip and chronic cough. And if this infective material is ingested, so it may lead to the pneumonia of patient. And flaring of the alveoli nasal, that means the patient is in respiratory distress. Either it may be the exacerbation of the COPD or exacerbation of the asthma or exacerbation of the any airway disease. And there is some nasal deformity, there is the DNS. DNS ultimately may lead to the sinusitis. And nasal polyps are very much important because these polyps are mostly from the allergic causes and mainly associated with the asthma. And oral cavity, and in oral cavity we have to know the oral hygiene, particularly the teeth, and in the caries teeth is present, and halitosis and enlarged tonsils. These are related to the lung infection. It may either lead to the pneumonia or lung abscess. Now come to the lower respiratory system proper. We first start with the inspection. In the inspection, we see first there is the shape of the chest and symmetry of the chest. Shape of the chest we have already been described in the anatomy. It may be either normal or it may be barrel-shaped, flat, excavatum or pectus carinatum. And symmetry of the chest you have to look for from the front, side and from the back, whether it is depressed or bulge, and particularly the supraclavicular area, any fullness or any hollowing is there. And the trachea, appears to be central. Sometimes it is located to the shifted to the right side slightly, but you have to know the trail side, either it is absent or present if it is visible. And accessory muscles are in respiration, these are used or not, and if it is used, whether there is any intercostal indrawing, and if it is used, that means patient in respiratory distress. And the apex bit, whether it is visible or not. And these are the point you have to note during the inspection. And this already been described in anatomy chapter. And also to know that infraclavicular area, whether any drooping of the shoulder or any crowding of the ribs, it is visible or not. And chest deformity, that is the kyphoscoliosis or not. Any skin we see any, it is either it may be normal or there may be dilated vein, any scar mark or sinuses. And discharging sinus, that may be from the chest wall, and it may be from the pleural cavity also. And movements, and appears to be either equal or it may be diminished of the pathology of the pleura, either pleura or lung. Now come to the palpation. In the palpation, just like we see any local rise of the temperature, any tenderness, and we have to corroborate the inspiratory finding to be confirmed here. Now we see the trachea just to see whether the trill sign is present or not, and the apex beat that is palpable normally at the left hip intercostal space 1/2 inch inside the mid-clavicular line. And there's also you know the chest movement, then tactile or vocal femmeters, and it may be normal or it may be increased or decreased depending on the lung pathology, and the crowding of the ribs. Now this is the position how the chest wall expansion is measured or by palpation. First one is in the apical area, this one is the apical area, second is the posteriorly, and this is the anterior area. And this is how to know the vocal femmeters. There is the topographical area, they already described. There is the anteriorly, there is the posteriorly, there is the suprascapular, interscapular and infrascapular area, and in the axillary, and from the right side and the left side. Now there are some measurement, and the measurement will helpful particularly to know that about any underlying chest deformity and also the chest condition. Particularly in case of any outward deformity is there, either it may be in the form of barrel chest or it may be pectoralis excavatum, carinatum, so we can identify by looking also by measurement. And the chest circumference, this is very much important. This is a chest expansion, and this is important because normally if there is restrictive lung disease, the chest expansion is below the 2 cm. Normally it is 2 to 4 cm. And the percussion, and normal percussion is the resonant. It is all around the lung fin, but whenever it is hyperresonant, it may be impaired, it may be dull or stony dull. Hyperresonant, if there is any air, there may be hyperresonant, that means there is any pneumothorax, or it may be impaired or dull or stony dull, that depending on the pleural pathology or lung pathology. And if there is pleural effusion, it is dull or stony dull. And you have to know the liver dullness, and liver dullness is very much important just to know the expansion of the lung. If the lung is hyper expanded in case of COPD or any other disease, the obstructive airway disease that causes the air trapping, this liver dullness is obliterated. And there are some special tests like your shifting dullness, and it occurs in the hydropneumothorax, chronic isthmus percussion, and also the top space percussion. And under this area where we percuss this area, anteriorly there is the supraclavicular, infraclavicular and mammary area, and here is the axillary and infraaxillary area, and in posteriorly there is the area that is the suprascapular, interscapular and infrascapular area. Now come to the auscultation. Auscultation, mainly we found the breath sound. Whether this breath sound, character and intensity of the breath sound, whether it is normal, equal on both sides, or whether there is diminished in either side, or they associate some other features or some added sound. So the character and intensity, there is the bilateral normal vesicular breath sound with the equal intensity. It is normal, and it may be abnormal, either it may be bronchial, it may be cavernous or amphoric breath sound when there is a cavity is there, and bronchial in case of any consolidation. And some added sound, there is a rhonchi and crepitation. There is the musical sound produced by the airway. It may be monophonic or polyphonic, and polyphonic we usually observe in asthma. And crepitation, there is the rustling sound due to at the end of or the opening of the small airways, and it may be following time, it may be early, it may be mid or late inspiratory crepitation. So early inspiratory crepitation is found mainly in the bronchiolitis, mid in case of heart failure, and late inspiratory crepitation we found in case of interstitial lung diseases. And the vocal resonance, either it may be normal, increased or decreased. There are some specific tests we usually not done in all the cases, but in case of Sarkison's class, in case of hydropneumothorax and post-acute crepitation, when we see any cavity or there is any amphoric breath sound or cavernous breath sound. This is the normal breath sound. There is no gap between the inspiration and expiration, but in case of the bronchial breath sound, there is the expiratory phase is prolonged, and there is a gap in between the inspiration and expiratory phase. Now examination of the other system, you have two examination, particularly the CNS, CVS, GIT and musculoskeletal system, and you have to find out if it is normal, then we have to write normal, or there may be some possibilities, particularly in case of COPD, there the alteration of the mental status is there because of CO2 retention. In case of lung carcinoma, if it is metastatized to the brain, so there may be altered sensorium is there, and CBS is very much important just to rule out any valvular heart disease. That is, and you have to write either any murmur is present or not. So whenever you write the provisional diagnosis, you have to write the side, which side of the lung is involved, either right or left, and at the same time lobe, in which lobe is involved. There is the upper lobe or lower lobe or middle lobe, but it is not to be right in case of pleural effusion, because it is extrapulmonary and it does not have any relation with the lobe. And the probable pathology. Now this is the abbreviation, or there is a take-home picture of this clinical examination, and if you go through that, there is some starting from the face only. You have to identify any cyanosis there, any ptosis or Horner's syndrome. So there is maybe the possibility of the lung carcinoma, and from the neck only you see there is any lymph node is there, JVP is raised or not, and accessory muscles of respiration are used or not. Now comes to the hand, there is a clubbing, any peripheral cyanosis, tobacco staining, and carbon dioxide retention, and it may cause flap. And general observation is like respiratory rate, then body mass index, whether it is obese, lean and thin, or there is a weight loss, and patient mental condition, confusion or distress. And on chest examination proper, you should write there any scar is there or not on inspection, like any deformity, scoliosis or Pigeon chest. On palpation, we see just to see the tracheal position, also the apex beat. And percussion, there is a note, there is either it may be resonant dull or stony dull. And auscultation, just to know the breath sound, whether it is vesicular or bronchial breath sound and air sound are present or not. And abdominal examination, particularly that related with the respiratory system, we have to identify any hepatosplenomegaly or sacral edema. And legs, we have to identify any bilateral edema in case of cor pulmonale, or unilateral edema, that is in case of deep vein thrombosis. And there are other two things are there, just like if you have to identify any nasolabial crusting, that is any herpes labialis infection in case of pneumonia. And also there may be some other lesions in the chest only. These are called the lupus pernio in sarcoidosis. So you have to inspect the face very carefully, because it will give the impression of which of the underlying disease the possibility is there. So this is the gist of the total clinical investigation of the clinical examination of the patient having respiratory distress or respiratory symptom. Thank you for patient hearing.